All right, so we're going to start today's webinar on chronic migraine. Our guest speaker tonight is George Nissan. George Nissan is an attending physician at Baylor University Medical Center, their headache center in Dallas, Texas. He's a clinical assistant professor of medicine at Texas A&M College of Medicine in College Station, Texas. He is board certified in internal medicine and headache medicine. He was an attending physician and later co-director of Diamond Headache Clinic in Chicago from 2003 through 2011. His medical practice involves both outpatient and inpatient management of chronic headache disorders. He has published articles on migraine, chronic daily headache, and cluster headache in medical journals and for the general public. Dr. Nissan, would you like to begin?
Yes, thank you. Thanks for the introduction. The topic of this is chronic migraine. Now, it's a broad topic. I'm going to start, if you can go to the next slide, please. First, I'm just going to kind of define migraine before we talk about the chronicity of the disease states. Migraine is the primary recurrent episodic headache disorder. It's typically one-sided and throbbing. It's associated with nausea, vomiting, sensitivity to light, sound, and head movement. Visual aura is usually occur in about 15 to 20% of patients. That means that about 80 to 85% of patients do not see what we think of as those quintessential changes, and I'll show you a picture of the auras in a couple more slides of what that looks like. Inherited tendencies, so there is a genetic component to migraine, and a lot of people may have seen this on TV recently. I was actually less than 2 months ago. There was a researcher at the University of Utah that discovered that the level of the genetic mutation for migraine may be at the prion level, which is sort of these small proteins. And we're thinking now, what we've known for many years that migraine has a huge genetic component, but now we're actually seeing it with current technology, so it's a nice topic for the future. And as we know with migraine, it's also frequently associated with disability. Next slide. The accompanying symptoms that we see with migraine are nausea, vomiting, diarrhea, sweating, cold hands, light sensitivity, sound sensitivity, scalp tenderness, and pulsating pain. We know there's many more, so these are typically the most common things. Most people complain also about smell sensitivities. They anytime you think of the migraine brain, you think of hypersensitization of the brain, so things that would normally not be bothersome start becoming bothersome for people. So, smells, exposure to different triggers like chemicals, solutions, things like that, perfume, cologne. And so you really see this heightened sensitivity in the brain. Next slide, please. There's also what we call prodromes or premonitions associated with migraine, and those include things like a feeling of well-being, talkativeness, surge of energy, hunger, anorexia, or just lack of appetite, drowsiness, depression, irritability or restlessness, or neck tension. So there's a lot of things that people describe, and this is not an aura. An aura is actually a visual change that occurs in a small percentage of migraines. Prodromes definitely occur, and patients describe it where they'll say that a few hours before their headache starts, they'll have this insatiable surge of energy, or almost like a sense of hyperactivity, or they get very drowsy and fatigued, or irritable, and or they have multiple different premonitions before that headache starts, and then they know that in a few hours from now I'm probably going to get a headache. Next slide, please. This is what a typical migraine aura looks like, and we talk about the fortification illusion of migraine, and people really do describe these visual changes with jagged edges. It's kind of an interesting thing when you have people draw what they see during an actual aura, and they really describe these. Some people describe loss of vision. And typically what happens is within about 30 minutes to an hour after the onset of these symptoms. So these type of symptoms actually only last for a few minutes, but then within 30 minutes to an hour afterwards is the onset of a very severe headache. Next slide, please. This is also another artist's rendition of what people see. You have this loss of vision in the center, and you can see these jagged edges that are shown on the slide as well. It's kind of an interesting thing that people draw these visions that they see with their auras. This is just another type of aura that's described commonly by patients. Next slide, please. So what we're going to talk about now is the pathways of migraine and how this relates to what we call the chronification of migraine. So remember, migraine is typically an episodic headache disorder, meaning that it occurs, once or twice a month, or sometimes even less than that in the majority of the patient population. But there is a small percentage of people that undergo the chronification of migraine, or it becomes a chronic and very frequent type of disease. So when we look at the pathways of migraine, this is in contrast to all the years when we all started studying headache, decades ago for some of the headache docs. What we learned was the vascular pathway of migraine, which is you have essentially opening and closing of blood vessels in response to some type of stimulus. And we now know that that's not really what happens during a migraine. And over the last 20 years, the development of technology, we're able to really see, you were able to actually see the pathogenesis of the pathway of the migraine. And what we know is that migraine signals typically originate in the brain, in the deep within the brain. If you can click the next one, it's number 2. And then electrical impulses spread to other regions of the brain. This is what we call that heightened sensitivity. If you can go to number 3, please. Changes in nerve cell activity and blood flow. And may result in visual symptoms such as visual disturbances, numbness or tingling, and dizziness, because as we all know with migraine, people describe multiple symptoms other than just head pain. They describe things like vertigo, dizziness, lightheadedness, numbness, tingling, hypersensitization to different stimuli. Next, number 4, please. Chemicals within the brain cause blood vessel dilation and inflammation of surrounding tissue. And this is really also a key factor that we know that not only is there blood vessel dilation, but you also have inflammation and this release of protein inflammatory mediators in the brain. Number 5, please. And then the inflammation that occurs in this chemical cascade irritates the trigeminal nerve, which results in severe throbbing pain. So the ultimate result and why people describe all these different symptoms associated with the trigeminal nerve is because of this irritation of that. The trigeminal nerve is the 5th cranial nerve. So there's 12 cranial nerves that innervate the brain, and the trigeminal nerve is the one that's primarily involved in migraine. And that's why people sometimes describe tearing of the eyes, droopiness of the eyelids, nasal congestion, and they think that they have what are called sinus headaches. And we now know that it's really migraine that's stimulating the signal that's irritating the trigeminal nerve. Next slide, please. Okay, we're going to talk today about migraine chronification, which is really a big topic from a headache specialty standpoint, because by the time patients reach a headache center like ours, the majority are in the chronic migraine phase. When we talk about the natural history of migraine, we think of this hypersensitization of the trigeminal nerve. It's also called central sensitization. And acute drug overuse is a major cause, but it's only one cause. And then what happens is the increased frequency of headaches ultimately will lead to this chronic migraine over time. That's why it becomes all important to keep the frequency of headache attacks low. That's what we focus on, is decreasing the frequency and severity of patients' headaches. So when we look at this, these different arrows, and we see that the frequency of headaches increase in the blue arrow. Then you develop sensitization and what we call central sensitization of the trigeminal nerve, and then ultimately that leads to drug overuse because people start getting more headaches and they become more inherently disabled from it, and they start using as much medication as they can to try to get by. Next slide, please. When we talk about chronic migraine, we got to define what chronic daily headache is. And when I see patients in my office, I always talk to them about this concept of chronic daily headache. And the International Headache Society defines and classifies chronic daily headache as a daily or near daily headache that lasts greater than 4 hours for greater than 15 days per month. So as you see, to be called chronic daily headache or chronic migraine, it doesn't necessarily mean that you have a headache 30 days out of 30 days of the month. As long as you have at least 1 out of every 2 days of the month some type of headache, that's already getting into the chronic phase of headache. When we look at we're going to be talking about chronic migraine, which is the most disabling and important topic to talk about in chronic daily headache. The second type of chronic daily headache is chronic tension type headache, which is definitely the most common type. It's much more common than chronic migraine. Next slide, please. Number 3 is new daily persistent headache, and I did a webinar on this last year. New daily persistent headache is kind of a subset of chronic daily headache in which patients describe literally they wake up one day or they develop some type of infectious process or some other etiology, and they wake up with a headache. It doesn't go away, it's there, and these are patients that have not had previous histories of headaches when they were younger. Hemicrania continua is the 4th component of chronic daily headache, and that's a daily headache. The hemicrania is half the head. It occurs on half of the head. Literally, it's only one side, never crosses to the other side. It's similar to a cluster headache in that you have tearing of the eyes on the one side as well as nasal congestion. It's a much less common form of chronic daily headache. Each of these subtypes can be further subdivided into with medication overuse or without medication overuse. So essentially, that's where we talk about chronic daily headache. The high percentage of patients have medication overuse associated with their diagnosis of chronic daily headache. Next slide, please. As far as the epidemiology of chronic daily headache, it occurs in up to 4% of Americans. So when we think of this, and I always talk about this with my patients, it's not that uncommon. So if you go into a room with 100 people, at least 4 out of every 100 healthy people will have a headache every day, which is a pretty staggering statistic. So we think about the U.S. population, there's about 310 million people or so. 4% of those, so about 13 to 14 million people have a headache every day or almost every day. Chronic tension type headache is the most common subtype. It's highly associated with medication overuse as well as comorbid depression. The medications that are most commonly overused in chronic daily headache are over-the-counter analgesics and primarily drugs like Excedrin, which contain acetaminophen, which is Tylenol, aspirin, and caffeine. These are a combination analgesics that are highly known to cause medication overuse headache. Then the opioid narcotics are also commonly overused. Those are things like hydrocodone, the trade name is Vicodin or Lortab, or Norco. There's barbiturates, ergotamines, and now we're seeing, especially over the last decade or so, is overuse of triptans. So those are drugs like sumatriptan, Imitrex, Zolmitriptan, Zomig. Basically, those drugs are not designed to be used more than twice a week, and we're not uncommonly seeing people that are taking it on a daily or almost everyday basis. Next slide, please. Migraine prevention is really the key thing is when we talk about chronic migraine. And in a study, this was by Dr. Steve Silverstein in Philadelphia. This was published in the Journal of Headache in 2003. And what we know is that the impact on the quality of life of a patient is very huge when you reduce the frequency of their migraines. And when they did a retrospective analysis of a large claims database, this was over 10,000 patients, they found that using acute and preventive therapies resulted in decrease in ER visits by 82%, decrease in ordering unnecessary scans by 75 to 88%, decrease in office visits by 51%. So it makes a huge impact on a person's life. Next slide, please. When we think about migraine prevention therapy, we talk about when do we decide to medicate and use prevention therapy in someone with migraine. And what we look at is if the frequency of the headache is greater than or equal to 2 times a month with disability greater than or equal to 3 days a month. And that's really an important thing is to find out, because if a patient only gets 1 headache a week but it lasts for 7 or 8 days, that can be very disabling for them too. And those are patients that you would think about initiating migraine prevention therapy. When we think about chronic migraine, all the patients fall into that category. They're all having at least 15 headache days per month. So at some point, you have to think of some type of preventive therapy. If it's the migraines that, in the patient's opinion, significantly interfere with their daily routines, those patients definitely need to be on prevention therapy. If they're overusing acute medications greater than twice a week, if acute medications are contraindicated, for instance, people that have a history of heart attacks or stroke cannot be on triptan drugs, which constrict the blood vessels. Those patients absolutely need to be on daily prevention therapy. The presence of uncommon migraine conditions, things like hemiplegic migraine, which is migraine that looks like stroke, where you have paralysis on one side of the body, also slurred speech, droopiness of the eyelids, droopiness of the mouth as well, and then attacks with risk of permanent neurological damage. So these are really and these are just generic guidelines that the American Academy of Family Physicians and the American Board of Internal Medicine have recommended. It's pretty much established as the guidelines. Next slide, please. Now, are there other criteria that should be considered? Well, we also think about escalation in migraine frequency and duration. So someone, for instance, who's had 4 headaches a month for most of their life, all of a sudden they're having 13 or 14 headache days per month. They're getting very close to that chronic migraine threshold. Those absolutely should be on some type of prevention therapy. And if they're increasing their use of acute medications, that may put them at risk for rebound headaches. So that would be things like someone who is maybe taking Tylenol once a week, and all of a sudden they're taking Tylenol 5 days a week, or almost every day, and those patients absolutely need to be on prevention therapy. Next paragraph, or next slide, please. The goals of migraine prevention therapy are really simple, and when we look at it, we think about reducing attack frequency, severity, and duration. We want to improve function and reduce disability, and that's really very important because the amount of pain is not the important thing. It's actually the amount of disability that the patient is experiencing. So if people all have different pain thresholds, that's why I ask them, what if they tell me their headache is a 7 out of 10 on the pain scale, I want to know what's their level of functionality when their headache is a 7 out of 10 versus a 4 out of 10. Because that really, your goal for prevention therapy is to reduce the overall daily interference with your activities of daily living. When we think about migraine prevention, we also want to reduce the use of acute medications and the potential for rebound headache, because rebound headache is an incessant cycle that if it's not broken, it'll keep the patients continually in a chronic migraine cycle. Improve responsiveness to treatment of acute attacks, and this is also really important that when you're on adequate prevention therapy, when you do get breakthrough headaches, you should be able to treat them with more effectiveness when you use acute medications. Next slide, please. So the principles of management, when we think about medication use in chronic migraine, we want to initiate therapy with the lowest effective dose. And every patient has a different threshold for what they can tolerate for side effects. And we know, and I'll show you in a couple more slides down the road, I'm going to show you what some of the common meds are used in migraine prevention. But each class of migraine preventive medication has its own set of side effects. And they range from anywhere like benign things like dry mouth, constipation, dry eyes, to more severe things like cognitive memory changes, sedation, things like that. So there's a lot of different side effects that we have to look at. We usually will start with the lowest effective dose, and we try to increase slowly until the clinical benefits are achieved. So you want to sort of balance out the best benefits versus risk ratio with each medication. And you want to give each treatment an adequate trial. And this slide says 2 to 3 months, which is from the evidence-based guidelines. But I usually say like 1 to 2 months minimum for an adequate trial before you make a judgment on whether preventative is working or not. Then you want to avoid interfering medications, because that's a lot of patients with migraine may have other disease states like diabetes, high blood pressure, depression, things like that. So you have to look at drug-to-drug interactions, because that may also increase the level of side effects. Next slide, please. As far as patient education, when we discuss with patients the overall management of chronic migraine, we like to discuss the rationale for treatment, when and how to use the medications, and then the potential side effects or adverse events that are common with it. It's very important to be educated on these things, because I think what happens to a lot of patients when they're in a busy like family practice, when they see their doctor or a general neurologist who doesn't really have the time to spend on the medications, they're given samples of medications, or they're just started on meds and they're not told really what to expect with it and how to titrate the medications correctly, and it leads to a very low rate of compliance. And you want to set realistic expectations regarding the benefits and time frames. So what we like to do is say, okay, you got to wait. You're not going to see a change in 3 days or 4 days or even 3 weeks. You want to give it about 6 weeks or so, and really be open-minded to to understand that there's going to be side effects associated with these drugs before you see the benefits of them. Next slide. As far as evaluation goes, what we have patients do whenever they're followed, especially in a tertiary headache center, we want to have them keep a headache diary. Because what we've seen is when patients don't keep a headache diary, they tend to do what we call minimization of their symptoms, and they basically, when they say, hey, I have only 12 headaches a month or 13 headaches a month, then you look at their calendar and they have 27 headaches that month. And they didn't realize until they started really looking at the data that there were very few headache-free days. And we know that as migraine becomes more progressive, that the amount of headache-free days becomes less. So keeping that diary really does give us a better benchmark so the doctors can follow this and patients can understand what's actually happening on a month-to-month basis. What we want to do is measure the attack frequency, severity, duration, disability, and side effects of medications. Those are all typical things that we have to do on each follow-up visit. And you want to reevaluate therapy as needed. So essentially, we look at keeping a good headache log, monitoring the use of the acute medications to treat the pain, how disabling the headache is, what's the duration of the headache, is it 4 hours, is it 24 hours, is it 72 hours? Some people have a headache that lasts a week and it doesn't get better at all during that week. Next slide, please. What's interesting is when you look at, this is the old American Migraine Prevention and Prevalence Study, or AMPT Study. This study occurred over 10 years ago. What was interesting, the only reason I provided it in here was that what I thought was interesting when you look at it, out of the people who need preventative therapy, when they looked at 19,000 people that had migraine according to the diagnostic criteria of their medical history, which was basically people that had at least 3 headache days per month and headache disability greater than 2 days a month, 39% of all migraine patients in a practice were eligible for that, but only 1/3 of those, or 13%, received prevention therapy. So that leaves this huge gap in people that are not getting treatment. And those numbers have gotten better somewhat over the last decade, but they're not dramatically better than that. Next slide, please. When we think of preventing chronic migraine, I do like this slide because there's certain key things you got to remember. When we talk about eliminating triggers and modifying lifestyle, and I'll show another slide coming up soon about what we want to talk about. Headache triggers can be somewhat easily found and sometimes not so easily found. Those are things like certain foods, certain changes in weather, barometric pressure systems, stress, lack of sleep, daytime naps, not exercising, deconditioning. There's so many different things that can trigger off headaches in patients, and you got to learn with each patient to really think about that. To look at we look at each person as an individual, because each person is so different in how their headaches are triggered. When we talk to patients too, we talk about using symptomatic medications very judiciously. So about 2 days a week or less is really your goal. And you want to use rational and preemptive migraine prevention. Next slide. When we think about preemptive prevention, what we're thinking about is we want to anticipate the increases in headache frequency, even if they're not dramatic. So if someone, for most of their life, had headaches 3 to 5 days a month, and all of a sudden they go up to 10 or 12 days, you have to be preemptive and really take a good stake in thinking about this, about going into preventive therapy and modifying lifestyle. And especially when someone starts increasing their intake of acute medications, even if they're not completely over, because not everyone overuses meds, but a lot of people start increasing their intake of it. And then when we think about situations that are known to increase headaches, like stressful situations, death, birth, things like that, those are all important things to think about preemptively. Next slide, please. When we want to achieve effective prevention, first of all, we want to arrive at the proper diagnostic category. And I think patients, really, when I first see a patient, I like to ask them, what is the diagnosis that you've been told you've had over the years? Because most patients have seen many, many doctors, including OBGYNs, family doctors, internal medicine docs, neurologists, TMJ specialists, other dental specialists. And it's interesting what kind of diagnoses they come up with. And it's very important for patients to understand their true diagnostic category of what kind of headache they really have. And you want to address the overall impact of the disease and what other comorbid medical conditions are there. So you got to look at everything, the entire patient, and how does the disease affect their day-to-day life, and what other medical problems do they have in addition to the migraines. Open communication is very important too, and we talk about side effects, realistic expectations, the plan of action. Next slide, please. We want to use optimal doses and balance between therapeutic and side effect potential. So we want to get to that therapeutic level. We also we have to be mindful of the side effects each patient is experiencing. We also want to stress the harm of overuse of medications, acute medications. Those are things like over-the-counter and prescription meds. What I like to do is I talk about patienthood, not parenthood, but patienthood, which is basically empowering a patient to make their own decisions. Migraine patients need to have total control over their own care and total understanding of their disease. We want to use evidence-based decision-making strategies based on evidence, and I'll show you some of the things that we have on there. And we want to support your well-being, not a progress. It's not like cardiology where a patient comes in and they have a heart attack and they're having chest pain, shortness of breath, and they wind up getting they show that they're positive in their cardiac enzymes for a heart attack, and you go into the catheterization lab, you get a stent placed, you get a angioplasty completed, and then you're a new person kind of thing. And that's not what migraine is. Migraine is a process of each person is totally different the way they present. They may have similar presentation, but they're not exactly the same, and the treatment's not going to be exactly the same. Next slide. When we talk about adherence studies, and I also like to show this slide, is that when we looked at different studies of chronic migraine, what we see is that about 50% of patients do not adhere to their treatment regimen. And what we see is that the least adherence is in exercising, which I'm a very big proponent of. My patients know that very well. And stopping smoking is the other thing that we have problems with getting people to adhere to. And so we try to set realistic goals with that too. And I think that it's extremely important to do these lifestyle modifications, and they're as important or more important than the medications themselves. And then you want to do some type of commitment change and write it down. Next slide, please. This is what we call the daily lifestyle ABCs, which I think only part of it didn't come out very well, but oh yeah, if you can keep clicking it till we get D, E, and F. Okay, perfect. Basically, what this is the structured treatment plan. When we think about this, is kind of a simplistic slide, but when we look at the different lifestyle modifications that we want patients with chronic migraine to do, we talk about regular exercise. And I always tell patients at least 4 to 5 days per week, and not just walking the dog around the block. And it's very, very important to get regular cardiovascular exercise. The other thing is tapering caffeine, because when we think about drugs like Excedrin that contain 65 milligrams of caffeine, if someone's taking 6 Excedrins a day, plus they're drinking 3 Diet Cokes a day, and each Diet Coke has 40 milligrams of caffeine, you might be taking in 500 or 600 milligrams of caffeine. And we're not saying completely get off caffeine, although that would be preferable, but really to put a realistic goal of, I would say, less than 50, but certainly not more than 100 milligrams a day. So you think about 1 can of Coke is about 40 milligrams a day. We think about fluids. We also want to maintain hydration, especially if you're exercising. Dehydration and volume depletion are very big components of initiating migraines. So if you're out in the hot sun watching your kid's baseball game, make sure you adequately hydrate and keep yourself hydrated throughout the day. Regular sleep and regulating sleep is extremely important, 6 to 8 hours a night. When a lot of patients start losing their normal regulatory mechanisms to initiating sleep when they're in a chronic migraine cycle, and that's one of the things you want to work on too, is trying to avoid daytime naps and really keeping your sleep as consistent as possible. Don't skip meals. So some people think, hey, I'm going to skip breakfast and just eat a small lunch and a big dinner each day. And that's not a good deal, because it's not the amount of food that you're eating, but it's the regularity of it. Just like you want consistent exercise and consistent sleep, you want to make sure that you're not skipping meals. Then you want to consider stress relaxation like biofeedback techniques or yoga or some other form where you can kind of dissociate from the stresses of work and being a parent and being a student. Next slide, please. Now we talk about pharmacological approaches to migraine prevention. I'm just going to briefly touch on this. If you can, next slide. Okay, this is kind of, when we talk about patient prevention preferences, when we look, and this holds true in any headache clinic that you talk to, most patients obviously wanted out of, this was a study of 125 headache subjects, and it asked them what do they want out of a medical treatment for chronic migraine. And when they look at it, the majority obviously wanted effectiveness. 12% said speed of onset, and 6% said absence of side effects, which I thought was really interesting. Is in our practice, when you talk to most headache specialists, side effects are talked about the most things of anything. So not even talking about effectiveness or speed of onset of the medications, but in this study, only 6% of people were concerned about not having side effects. So I think it's very interesting, because in reality, I'd say it's more like 75% are concerned about side effects. And then if you look at the type of treatment, where it's a prescription or an herbal supplement or a vitamin, that wasn't as much of an interest to a lot of patients. Next slide, please. This is kind of an old slide too. It's been modified. This was from about 6 years ago, the U.S. Headache Consortium Migraine Prevention Guidelines. And I'm not going to go into really big detail of the different medications that are FDA approved for migraine. There's only, if you look at the slide, there's only 4 drugs that are FDA approved for migraine prevention. When we look at divalproex, which is the brand name is called Depakote, and topiramate is Topamax, they both have quality of evidence that's A. When we look at evidence, we look at A, B, and C. A means that there are highly randomized controlled clinical trials that show them to be effective. B is sort of they're effective, but they haven't been consistently shown to be that. And C is really more clinical and anecdotal. There's not a lot of scientific data to support its use. So if you look at divalproex and topiramate, they have the highest quality of evidence, and so does propranolol, which is one of the beta blockers or blood pressure lowering meds. But if you look at them too, their adverse effects, they tend to have more side effects. So if you see the more effective the drug is for migraine prevention, you also see a lot more side effects. And like the neurostabilizers, which are the anti-seizure medications, are on top of that slide. The 3 drugs up there, they have different side effects like sedation, numbness and tingling of the hands and feet, grogginess. There's a lot of different things that you see. Hair loss can occur, so there's a lot of different things that can happen. So you have to weigh the risks versus the benefits. And then when we look at the antidepressants, if you look at it, these are the old antidepressants, the old tricyclic antidepressants like amitriptyline. There's also nortriptyline, doxepin, but amitriptyline has A-level evidence, so it's equivalent in efficacy to the or anti-seizure type medications. It also has several side effects, including dryness and constipation and things like that. And so that's another drug. It's very inexpensive. Amitriptyline costs about $3 a month if you go to Walmart. And basically, what happens is that you have a lot of people. They'll start, and even when you start at low doses, they get these side effects, and they get very intimidated by this kind of medication. You have to have realistic goals when you start something like this. There's other types of. If you can switch to the next slide, please. When we look at calcium channel blockers, if you look, verapamil has quality of evidence B, so it's pretty good. Diltiazem really has no evidence, so there's very few in that class that show them to be effective for migraine prevention. And then there's other listed drugs here too, and you can go to the next slide. When patients ask about nutritional supplements and herbal treatments, what we've seen, I've kind of broken it down on the next 2 slides, is some of the most common things that we use in supplements. And this is more for not really chronic migraines. So these are for patients that don't have as many, or people that can't tolerate prevention type therapy with prescription medications. There's a lot, feverfew is mentioned a lot, and there's several clinical trials that have been done, and they've had some results showed good positive benefits and some show no benefits. So it's very debatable. And we look at magnesium, which I like to use anywhere from 400 to 800 milligrams, and 500 is typically the most common. 3 of 4 controlled studies showed benefit in migraine. Riboflavin, which is also called vitamin B2, 1 controlled trial showed effectiveness at 400 milligrams a day. So that's also something you can do 100 milligrams twice a day or 200 milligrams twice a day. It's all available over the counter. Coenzyme Q10, 1 open label study showed decreased headache and medication use, which is good too, but it's also, remember, that was an open label study, meaning that patients knew that they were getting real coenzyme Q10 and not placebo. So the results may have been skewed on that. Next slide, please. There's butterbur extract. The other word for this is Petadolex, P-E-T-A-D-O-L-E-X. 2 controlled studies showed some benefit at a dose of 75 milligrams twice a day, so that's also an option for some patients. Melatonin at night to help with sleep can show some benefit too. And then hydroxytryptophan, there's a high placebo response rate. We don't generally use that a lot in migraine, although it does help with initiating sleep. Next slide, please. The one drug that patients always ask about is onabotulinum toxin A, Botox, which is the only FDA drug that is approved for treatment of chronic migraine. It got FDA approval in 2010. And basically, that one, we've been using it since the late 1990s in chronic migraine, and there's been a lot of different protocols that were designed, and we were typically using about 100 units until the FDA approved this in 2010, and what they approved was 155 units of Botox, which is 31 injections of 5 units piece. That equals 155 units. 16 injections go in the back of the neck down to the shoulder blade and the trapezius muscles, and then the other 15 go in the frontal and temporal aspects of the head. And the effect of the headache severity and frequency can last up to 3 months. So there's definitely some benefit to doing that, for some patients. But then what's interesting, and I added this to the slide, was that in the current edition of the Journal of Headache, the Journal of Headache and Face Pain, there was an interesting editorial in there, and they talked in May 2013, this past month, about the high placebo response rate in clinical trials that continue to exist today. And that's the interesting thing that we see is that what we found, and this happens because I really see a 50-50 split. Some patients say it's the greatest thing ever. Some patients say it did nothing for them. And it really pans that way. What's interesting in the clinical trials was that if someone got just saline injected in their forehead and didn't know, within a month they would probably know because they saw that if they had real Botox, they probably would have decreased frown lines and they'd have more clear skin in their forehead and their neck regions. So it's hard to tell, were these patients truly blinded from knowing whether they got real Botox or not. And I think the power of media persuasion can be very high as well. So you really have to weigh the advantages with your physician about whether you want to go ahead with this. But it is FDA approved for chronic migraine, and most, not all, insurance companies do approve it, but it just takes a while to get this going. It was interesting that before it got FDA approved for migraine, it was probably easier to get it approved by the insurance than it is now. Next slide, please. When we talk about new areas of research in migraine, and this has been the time-tested question, or what are the medication alternatives to triptans? We think about triptan drugs like sumatriptan, which is Imitrex. That came out in the early 1990s. It was available in Great Britain in the late 1980s already. So it's actually been out to the public for almost 25 years, in the United States for almost 22 years. So it's an interesting thing, and those are still considered the benchmark of acute management of migraine. And as we know, they all have they do have side effects. There's some people that cannot be on it. And when we think about new areas of research in migraine, also the risk of overuse, what we think about are alternatives to those. And there's been a lot of different medications that have been tried. And people probably read in the literature about the calcitonin gene-related peptide inhibitors or CGRP inhibitors. And those kind of medications, they showed a lot of promise as good alternatives to the triptans. And when we looked at it, we're still waiting because there's been difficulty with side effects and safety data, and the FDA has really been holding on to these things. And we haven't seen anything new come out. There's only a few drugs that have come out in recent years as alternatives to triptans. So the new interesting areas of research are going to be geared towards what can we use alternately that will not lead to rebounding and will be safe to use, and it doesn't affect the blood vessels. The other thing that's an interesting area of research currently is the use of non-invasive nerve stimulators that target the vagus nerve. And there was some failed studies about 7 or 8 years, actually it was almost 10 years ago now, in the early 2000s, what are called vagus nerve stimulators. And the vagus nerve controls a lot of pleasurable activities in the brain. And they use vagus nerve stimulators for people that have refractory depression, like the depression that's uncontrolled with medications. Psychiatrists will sometimes refer patients for that. And what they found was that they thought that that might help with migraine as well, though the studies have been conflicting on it. And it's a very invasive procedure. So there's a couple companies that are now looking into using these external stimulators where you actually will trigger them yourself without having it implanted that target the vagus nerve. And that shows to be potentially some kind of promising form of research that's non-medication based. So that's one of the things that we're seeing now. So we're looking at new forms of treatment alternatives to triptans and non-invasive nerve stimulation. Next slide, please. As far as a summary of migraine prevention, we want to identify triggers. We want to work on lifestyle modification, which includes regular exercise, decreased caffeine, good sleep hygiene. We want to utilize evidence-based decision-making strategies based on the strength of the evidence. And we want to avoid medication overuse to prevent rebound headaches. And that's really the key thing of all this is you want to be preemptive and identify migraine early on before it becomes chronic. You want to modify the lifestyle. You want to identify the triggers and modify those, and then work on strategies, both medical with medications as well as non-medication approaches for the prevention. And I'll open up to questions.
All right, so we got a couple different questions on food triggers, and the first one was, how much scientific evidence is there that certain food triggers even exist? If there's not much evidence, then why is there such an emphasis on food triggers by many sufferers and headache doctors? Because tyramine is said to be a common trigger for many people, but it seems inconsistent and varies with each person.
That is true, and that is true. I mean, there's not a lot of scientific evidence. It's been hard to prove tyramine's role in the development of migraine, but when you talk to patients and when they do their diaries, there is a fairly good, about 40% of patients in most practices have some form of food trigger, and it doesn't mean that every headache is going to be triggered by a tyramine-containing food, but it is something to think about, and it is a point of debate because theoretically, some patients have zero food triggers and can eat whatever they want, but when I start out treating patients, I typically want them to avoid foods that are aged and fermented, and those are things like aged cheese, red wine, pepperoni, sausage, things like that. They're pretty much described by patients. And there's also things like aspartame, for instance, which is found as artificial sweeteners, and things like Sweeteno and Equal and diet sodas. And we know from there that also, I mean, there's no scientific evidence that it triggers migraine, but if you talk to patients, you'll find out that they can tell the difference when they have something with aspartame versus non-aspartame. So I think to start out with, it's good to rule out food triggers. It doesn't mean that you have to adhere to it perfectly.
Carrie is wondering, just to clarify triggers, she's wondering if something is a trigger, does that mean that every time you eat that item it will cause a migraine, or is it possible that it is a trigger but not always cause a migraine?
Yeah, it's a good question too. It's definitely not always. So some people, for instance, could say they can drink wine or beer, and they find it to be a trigger 50% of the time. The other 50% of the time they're okay. So, but there are some people that really notice that certain foods or drinks are true triggers every single time. So there's no definitive answer to that question. So you really have to take it on. If you start noticing though that certain foods or drinks really do trigger the headache, it is advisable until you get the headaches under very good control to really avoid those things. Then you can gradually reintroduce them back into your food list.
All right. Michelle says, I find that I eat horribly when I have a migraine. I crave foods that are unhealthy, especially carbs. I try to eat healthy, but it's almost impossible because I go to what I am able to digest when I have a migraine. Do you have any thoughts on that?
About remaining, I'm sorry, could you repeat the last part of that too?
Sure. She says, I try to eat healthy, but it is impossible because I go to what I am able to digest when I have a migraine. So I think in relation to eating horribly and craving lots of carbs and stuff while she's having a migraine.
Yes, that is true. And also the nausea makes it somewhat difficult sometimes to eat healthier too. It's a delicate balance that you have to really find to make. You want to keep yourself well hydrated and eating as healthy as you can. It is very difficult, and I try to work with patients on that, definitely on changing their overall management, even when they feel nauseated or they start craving different things. You have to really work on that over time. It's not something that's going to change immediately. So it's just like with everything else, there's a risk and benefits to following some kind of trend like this. And diet, over time, especially I would say more importantly, is not skipping meals. And you need to get in, even if it's 3 small meals, and try to make it as healthy as possible, even when your body's telling you otherwise.
Also, you mentioned that exercise is important, and what happens when exercise makes your migraines worse? Is there an alternative?
There are ways to do it. There are meds that you can pre-treat before exercising. It is hard to tell someone that. I definitely force my patients to do exercise at least 4 to 5 days a week, even if they have chronic migraine. And you have to find other strategies, including sometimes preemptively treating before you go in, and eating something and then taking a medication before you go into the gym or do a more intense form of exercise. And I try to people not bend too far too, because bending and lifting heavier things too could sometimes trigger off a migraine. So you want to do just basic cardiovascular exercise until your body gets conditioned enough so you can do more than that. So that's another place where you have to set realistic goals.
Also, Judith asks, what's your opinion on OGG blood tests to identify food triggers?
Right. Well, the problem with that is that you may have, food sensitivities that are popping up on these blood panels, but the question is do they really trigger migraines in a patient? And that's why, I like to look at those. If patients bring them to me, I like to look at just to see what pops up on the screen. But, the reality is that just because you have a sensitivity or, a mild allergen to some foods, it doesn't necessarily mean that it'll trigger a migraine, because the mechanism of triggering migraine is not the same as being sensitive or allergic to a medication. When we think about the migraine brain, it's a hypersensitive brain, so things that wouldn't normally bother someone who doesn't have migraine does bother them when they're susceptible to migraine. So things like, if you turn out positive for sensitivity to barley or other things, it doesn't necessarily mean that barley products will trigger off a headache. So you can look at it as a guide, but it's not the definitive answer or the Bible for a migraine sufferer.
All right, we have quite a few questions on medication. Rosie asks, after taking Imitrex, I find that a migraine will often reoccur the next day and possibly the day after that. I only take Imitrex when a headache is bad or I have plans. I do not take them early on since I have too many false alarms and try to stay at 6 or less per month. Are these the same headaches?
It can be. The Imitrex works within about an hour if you take the pill, and the shot form it's about 20 minutes or so. And Imitrex is sumatriptan. It's one of the 9 triptans on the market right now. And basically, it does clear out of your system fairly rapidly in less than 24 hours. And it's possible that sometimes it is the same headache and not necessarily a new headache that pops up the next day. So, that's one of the things you have to think about, too, is if they come back, you're starting to use more and more triptans, you have to think of a new strategy of how to treat them and think of alternatives to treatment, either combining therapy and spreading out the use of the triptans, because it's very hard to determine is this a new headache or is this the same headache that just was masked by the triptans, for 12 to 24 hours.
Okay. Laura wants to know about the Medrol dose pack. That's her go-to rescue medication. And for the average person with no other medical problems, how often can you use this to break an acute cycle?
Well, the thing with steroids like Medrol is methylprednisolone. There's also dexamethasone and prednisone are the other 2 steroids that we use in headache fairly commonly. And you want to expose patients to the least amount of steroids that you can. Medrol is a 6-day pack. And so if let's say you have a woman who gets really severe menstrual migraines and wants to take it for all 6 days of her period, you really don't want to expose the person again later that month. You should never expose someone more than once a month. Just because the risks of the steroids are things like osteoporosis, glaucoma. There's different things that can happen systemically in the body with when we look at people that are treated with long-term steroids for Crohn's disease and rheumatoid arthritis, we know what can happen over time. So in a young, healthy patient with migraine, you want to limit your exposure to steroids like Medrol or methylprednisolone, and you want to really, there's no definitive answer to that either, but I usually do not let patients take steroids more than once a month. I try to space it out even further, like once every 2 to 3 months.
Sure. So Ray asks, when you decide that a period of total abstinence is required to break a rebound cycle, how long a period do you find to be effective?
It depends what the patient is taking. If you're rebounding on triptan drugs, for instance, it can take a while because the triptans, when someone is taking a triptan like Imitrex, which is sumatriptan, or Zomig, which is zolmitriptan, or Relpax, which is velatriptan, those are not easy drugs to come off of, first of all, when you're rebounding off of them. And you want to be off of them. What I like to do is get them, if I stop them cold turkey on a triptan, usually what I'll have them do is transition to a new medication. So you would do something very short term so you don't go into any withdrawal effects to it. And there's no, like you could stop a non-steroidal anti-inflammatory drug cold turkey without a major problem, or even things like Tylenol or Excedrin and things like that. It's just a question of what your body is going to feel like, because it takes a while to clear out these drugs. Even if a drug has stay in the body of 12 hours, it may take a week to actually clear it out completely from the liver and kidneys. So you want to totally detoxify your body. It takes a good week, and sometimes you may need to bridge it with other medications. But there's also no definitive answer, because I've been able to stop people cold turkey and get them off acute medications for a very long time, and others could not handle being off acute medications for 2 or 3 days even.
Jean asks, have you prescribed Diamox as a preventative med for vertiginous migraines? If so, has there been a positive response?
Well, Diamox or acetazolamide, which is a diuretic, it's an old drug that's been out for many, many years now. And its primary use is in a condition called pseudotumor cerebri, which is a pseudotumor is like a false elevation of spinal pressure that we see in some patients that are over, like for instance, obese women, or it can also occur in men in rare circumstances too. But it's not a common condition, and it's associated with a lot of different findings in the eyes. Those are the times I use Diamox or acetazolamide. I don't generally use Diamox for vertiginous type of headaches because there's really no data to support its use. It may work. I mean, I do use Diamox off-label for other things, but that's also one of those things. Sometimes I don't see a consistent response in patients with it. Next question, please.
Sure. Dexamethasone reduces my headache, but in a short time they return. Would it be better to take a higher dose of steroids to break the headache cycle?
It depends on the person. I mean, you can go to higher levels, and I've seen docs use high doses of prednisone, even up to 60 milligrams at a time, but the higher you go on steroid, the more risk you put your body to. And we try to use the lowest possible dose, but theoretically, if you use a higher dose of steroid, you may get a better response. So you have to weigh the side effects versus the benefits of the drugs.
Judy asks, do preventative meds like Topamax lose their effect?
The preventive meds can lose their effect over time. So some people that have had, sometimes patients describe that they did really well with the preventative medication for several months, and they started seeing eventually an increase in their headaches later on down the road, and they didn't think that the medication was working for them anymore for prevention. So there's some people that are able to take a preventative for years and years without a problem, and their headaches are well controlled. And once again, really each person is different. So yeah, I do think that there's sometimes people plateau and peak with their preventive medications, and then they start losing their effect in some cases. So that's also where you have to start modifying and sometimes taking people off of those meds and switching them out to different things, or looking for other combination therapies sometimes help.
You mentioned melatonin earlier as a alternative treatment option. What is the recommended dose for melatonin?
Melatonin comes usually in 5 or 6 actually it comes in 3, 5, or 6 milligrams over the counter. There's multiple different brand names, and you can find them in any store. But I usually start patients between 5 to 6 milligrams at night, primarily in the winter months too, when there's less light outside and when it gets dark by 5 o'clock or 4 o'clock in the afternoon. And it does help a lot of times to initiate improvement in the circadian rhythm. So what we see is that there's really, I mean, I allow patients to go up to 10 milligrams. I've seen people go as high as 12 or 16 milligrams on it. But typically most people fall in the 5 to 10 milligram range. And it's a nice, easy thing to dose because it typically doesn't make you feel groggy the next day. So the nice thing about it is that it really does peak in the middle of the night and starts tapering off as you get up in the morning.
In regards to treatment, someone asks, I have been suffering from chronic migraine for 4 years now and have tried nearly every preventative medication with nothing that has worked. And I have nearly 20 to 24 migraines a month. Is it worth going to an inpatient treatment center?
Yeah, the time to use inpatient or intravenous type of medication management is worth it in cases where people have maxed out on their therapy and they don't see any improvement in their day-to-day headaches. It's really more of a decision between a headache specialist and the patient themselves, because you want to, people have different reasons for wanting to go into the hospital, and really, if you're having 24 fairly severe headache days per month, that's probably someone that would be a candidate for inpatient management. So it really depends on the patient and what kind of symptoms they're having associated with the headaches. But if you failed multiple therapies, you may want to consider going in and utilizing an inpatient type of center. And so that's also something to think about. And maybe, if you see a general neurologist and they don't admit to the hospital, you may want to look into seeing a more tertiary headache specialty center. Next question, please.
Sure. We have a patient with an occipital nerve stimulator implant, and he is on nadolol and gabapentin
Not
as a
all.
preventive currently, or he's disabled because of his migraines, and he takes Percocet for emergency relief. The neurologist has referred him to a physician for surgical treatment of occipital nerves in the back of his head and ocular nerves around his eyes. Have you heard of any treatment like this?
Yeah, the question that always comes up with patients, because there's been a lot of media talk about this. I just had a reporter from the Dallas Morning News question me about it a couple of weeks ago, and it's going to be published soon in the paper. But there's a big thing going around now. There's a big movement for surgical management of migraine. And, you know, when we look at it, there's a lot of debate on this topic, and it's not currently recommended. And it really, you know, when I see someone that I'm not against doing surgical management. What you're talking about with surgical management of headache is they actually will decompress the muscle surrounding the occipital nerve, and then also the area around above the eye. That's the supraorbital nerve, which is above the eye. And essentially what it does is it's kind of decompressing. The theory is that if you decompress the areas, that you're providing less tension to those nerves and therefore less stimulation of the nerves, which should be better for you in the long run. And I'm more open than some of the other. Most headache docs are not really open to it. There's going to be an area of big debate on that. The International Headache Society is meeting in Boston this year, which most of us are going to in the headache world, and this is going to be a hot topic of discussion: is who is really truly a candidate for surgical management of migraine, and what kind of effective data is out there. So that's a very hard question to ask and to answer in a limited amount of time, and you really. I think that the patients that I would say that should seek out other alternative treatments are the ones that have failed multiple treatments and really are not very functional, and they want to try something completely outside the box because it's an expensive procedure, it's very detailed, and you have to really make a decision on that if that's what you want to do. So I can't give a decision, I can't tell someone whether to do the procedure or not, but I've seen numerous failures, so maybe I'm skewed in my thinking, but there's people that say that it does help them, so you have to keep an open mind and look at it in each individual case.
Cheryl has been recommended greater occipital nerve blocks. Is that a recommended thing to try before Botox injections?
Occipital nerve blocks are much different than Botox, and that's actually a good question. We do get asked that a lot. Occipital nerve blocks are directed only to the occipital nerve, and that's it. And you're basically anesthetizing the area or giving an analgesic and a steroid in that area to numb out the pain, and the effect can last for several days in some cases. Botox is more of a longer term. It lasts up to anywhere from 75 to 90 days in its effectiveness. They're not the same as far as effectiveness because there's actually good data to support the use of Botox for long-term prevention. Nerve blocks really are more appropriate if someone just has a really bad headache and they're not being able to break it with, with meds. Sometimes you can use the occipital nerve blocks as an adjunct to the medication, so it's a secondary form of treatment, and it can help for the short term. But it's not really a long-term solution. So the answer is you do not need to have an occipital nerve block before getting Botox. You can actually go straight to it. It just depends what kind of symptoms you're having.
Christine asks, is anyone researching the relationship between a sensitive gut and migraines?
Well, the sensitive gut we know certainly happens because nausea and other GI symptoms like abdominal cramping, are extremely common in patients with migraine, primarily also in younger patients. So there's been data talking about cyclical vomiting and migraine and different types of gastrointestinal type symptoms that correlate heavily with migraine. But I wouldn't say there's really research being done. There's not a lot. If you look at how much the NIH funds research, the National Institute of Health in Bethesda, Maryland, they give almost nothing. It's just a few $1 million a year, and with limited resources, most of the migraine management now or migraine research that's being done is new kinds of treatment options and looking at other ways of approaching migraine. So with a limited amount of money, other than pharmaceutical companies supporting drug therapies, there's not a lot in disease management type of research.
Yeah. What are your thoughts on the nerve stimulation device, the Cephally?
The one that I know, the StimPath, Is that the external stimulator? Is that what they're asking about? The external stimulator or the
Yeah,
internal
the
one?
one that's available, I believe it's the external one that's available in Canada and the UK currently, but
Oh yeah,
it
okay.
hasn't
Now
been
that
approved
one,
yet.
yeah. Well, that's a more non-invasive mechanism. I'm not against using that because I think that if you're going to opt to do something, you can try something like that because it's not invasive. It's available for a relatively low amount of cost too, and that's something that when I was talking about some of the new research in vagus nerve stimulators that may be coming out in the next few years too, that's also an option too because it's not going to harm anyone in any way. You don't have to cut or do anything with it, and I think it may help, and it's a good. I would definitely do that before doing any type of internal neurostimulators. Next.
Sure. Catherine asks, have you seen any correlations between migraine and elevated protein levels in the CSF? Can migraine explain the elevated protein level?
Typically, migraine does not. It elevates CGRP, which is at the cellular level. It's not typically the protein in the CSF is generally not related. CSF is cerebrospinal fluid or spine. The actual when you do a spinal tap and you look for different types of cellular markers like the white blood cells, the red blood cells, glucose, and protein. Typically, the protein is going to be normal in most migraine sufferers, so it's not really. You can't definitively prove that there's a correlation with changes in the protein. But at the cellular level, there's an absolute correlation with the release of calcitonin gene-related peptide in migraine sufferers versus those that don't have a migraine. Next.
Sure. We have time for just this last question, and it's by Laura, and she asks, what is progressive about chronic migraine? Is it actually a progressive disease? Can you say more about this?
Yeah, migraine, we used to think the old anecdote that migraine just goes away, or the old, what I call the old wives' tales, that people just assume, hey, I'm 25 years old and I have migraine. It's going to get better as I get older. And we now know that migraine has a progressive form to it, that if it's not attacked early, a lot of times it can progressively worsen over time. So we had this old paradigm years ago, like we used to say, oh, kids who are 10 years old, they're going to grow out of it, right? It's not really a progressive disease, and we now know that it's not true. So if you don't, when we used to think, well, we're just not going to do anything for someone who's younger because they may grow out of it, it's not going to progressively get worse. We now know that migraine does have a progressive component to it, and even though only a small percentage of patients develop from regular episodic migraines to chronic migraines, it's still substantial enough and it causes enough disability for people that you have to treat it as a progressive disease. So the answer is from the headache specialty standpoint, we do treat it that way, even though, the old paradigms of saying that everyone you just will grow out of it, it's going to be okay as you get older, because I've seen people that are, that waited like this for years and years, decades and decades, and they realize that, hey, my headaches aren't getting better, they're actually getting more progressive and worse. So we know there's something to it. And one of the things that we know with migraine, that it's a progressive disease, but it is manageable, and it also does get better in certain instances. Like, for instance, with natural menopause, we know that close to 80% of women have remission of their headaches just with the, but that leaves 20% that don't. So it's kind of, we know that there's still going to be progression in those in certain numbers of patients too. So you have to look at each individual case, and just like with everything in headache, it's not an open answer or a clear textbook answer, but I would say that yes, it is a progressive disease, but you also have to take each case individually.
Well, thank you very much, Dr. Nisan. Yeah,
thank you for having
I think we're wrapping it up for now. Yeah, and thank you very much for answering all these questions and the great presentation. Just as a reminder to everyone, it is Migraine and Headache Awareness Month. If you join us on Facebook, people are showing pictures of themselves with Show Purple, Show Support. Purple is the awareness color for this month. And we have at least 2 more webinars this month, the next one being Headache Myths on Tuesday, June 11th at 6:30 CDT. Thank you again for joining us.